Hello InstaFam, it's Dr. T here and I am on pickup from ballet duty. So I am coming to you from my car and it's perfect actually because I'm here by myself. I'm not being interrupted by anybody and I just got to keep the lights on so that I can see you, because at the moment I look like a little bit of a floating head. I hope you guys are really good. I wanted to talk to you tonight specifically about the IVF journey, and I want to make sure that all of our discussion stays kind of in that arena. So if you have any questions, to pop into the chat right now, anything you like about the IVF journey. Again, don't want to hear your life story, won't be answering any personal clinical questions, but I promise you, if there is a question that you've got, it'll probably be the same as somebody else's. So fire away. I have already had somebody drop a question into my post earlier tonight about how to get into IVF nursing. I thought it was such a great question. And if any of my nursing colleagues are on here, please guys, say hey and drop some guidelines into the comment section for everybody and I'll read them out. But basically, in order to become a fertility nurse, you need to have done some clinic nursing. So it's a clinic outpatient clinic role, so you would need to have done something like that or keen to move into that arena, and a lot of the training is on site. So our nurses often come from midwifery or they come from gynecology nursing, and a lot of the training they get around cycle tracking using ultrasound, transfers, surgical assisting, sort of embryo collection, egg collections, and hormonal management comes from what they learn on the job. So there is an amazing learning curve that happens. It is a very specialized field and there is a lot of training that is required on site. There's also a Fertility Nurses of Australia group that you can join and get lots of extra education, but I think it's a really clinically rewarding kind of role, and you work alongside embryologists and alongside scientists and alongside clinicians, so it's a really multidisciplinary team environment. I think it's an awesome career choice for anyone who is wanting to jump into that space. Now, I saw either some questions or maybe some comments. Let me flick back through. Here we go. Mum in the making. Lovely to see you on. Do you see any benefits of not repeating beta HCG every few days or only weekly? I think in the initial stages, it's not unreasonable to repeat a beta HCG after 48 to 72 hours. And if you do see that doubling, it can be reassuring. But by repeating the bloods every couple of days, when you know you're not going to see anything intrauterine until you've got a beta HCG above sort of 1500 to 1800, it's just anxiety provoking, to be perfectly frank. So I see more anxiety in patients who are studying their bloods intently and are getting repeated measures sort of every couple of days. I don't think it actually adds anything clinically. It doesn't change what we do. We can also expect to see a really nice doubling, sort of a tenfold increase after 7 days. So to me, it doesn't add any benefit, and in fact I think it creates anxiety. So I don't see any benefit in repeating it every few days. Now if somebody is symptomatic, they might have some bleeding or some pain, absolutely I would be repeating the HCG, because there is that small risk of ectopic pregnancy, and often we see a suboptimal rise in ectopic pregnancy, but that would probably be the only time where I would be doing the HCG earlier rather than later. Pascal Key, hello. Is it possible to simply make a bad batch, oversimplification, yes, when doing an egg retrieval? A bad batch? Not really. You can certainly get the dosings wrong and you can have an unexpected low response. and looking at our medications and tweaking them can sometimes get us better numbers. But are you necessarily going to see poorer quality in one batch and then not poorer quality in the next month? Generally not. Generally, the quality issue is a long-term thing. And we do have strategies that we try to, whoops, there goes my lights, that we try to improve egg quality, some adjuvant treatments, and I would encourage you to talk to your doctor about that. But generally speaking, let me turn my car back on again. Generally speaking, quality is a longer term thing, and as many of you know, quality is very commensurate with age. Sparkling 786, what is the age limit for IVF? Interestingly, I can really only comment on Australia. There are no age limitations. However, I personally have never seen an IVF pregnancy over the age of 45. That's with someone using their own eggs. Of course, you can get pregnancies with egg donation because that's all dependent on the age of the egg, not the age of the woman. But certainly IVF, I would not really be encouraging someone to do it over the age of 45. But there is actually no recommended age limit for who you can or can't perform IVF on in Australia and New Zealand. All right, good question. Andy B11. Is the likelihood of implantation increased when not done after a stimulated egg retrieval? No. We know that fresh embryo transfer and frozen embryo transfer have the same rates of implantation, they have the same pregnancy rates and the same live birth outcomes. So, and that's in the majority of populations. Obviously, there are specific populations who will do better with fresh or those who will do better with frozen. But generally speaking, the differences are non-significantly different. It's no significant differences. And so there are some clinics around the world who have such a good vitrification program, the embryology is really good, that they will offer frozen transfer to all. There are longer term implications, so we know that frozen transfers do result in larger for dates babies. But there are benefits to doing freezing because you can do things like PGT, or you can help to manage prevent ovarian hyperstimulation syndrome. So there are pros and cons, and I would certainly discuss it with your doctor. Kayla Reckley's. Dr. Tamara, do you mind touching on how to get into IVF nursing? I did, Kayla. I did. Way back at the beginning. So the long and the short of it is it's a clinic-based position, so it's not hospital-based nursing. It's a really good multidisciplinary team. You could do a master's in reproductive medicine if you want to learn, or a lot of the learning is done on the job. All the technical skills like cycle tracking and hormone tracking and ultrasound and embryo transfers and egg collections, they're all kind of on the job training. So it's a really rewarding job. It's a very small niche group, and there is the Nursing Society, the FNA, which is the Fertility Nurses Australia group that do a lot of extra. And Good question. Okay, what else have we got? Life of Brit, good to see you. Do you already know the gender of an embryo that you transfer? We don't. No, we don't. You can do pre-implantation genetic testing and know what the sex is. Let's not call it gender, because gender is something you choose to be. Let's call it sex, so it's either male or female sex. We don't know, but interestingly, I did a study once, and we found that 49% of embryos were male, and this is based on live birth rates, and 51% of embryos were female. So it's kind of a bit of a flip of a coin. But in Australia, you cannot do PGT for family balancing or sex selection unless it's related to a medical issue. So no, we cannot tell you. Even if we did know, we cannot tell you what the sex of your transferred embryo is. So we don't know. Georgie R. Ellis, why do euploid embryos miscarry? And specifically, why would they miscarry as a blighted ovum? blighted ovum is such a bad term, don't you think? A blighted ovum is really an embryonic pregnancy. So it's a pregnancy where the trophoblastic tissue that forms the placenta has continued to grow, but the little fetal pole has not continued to grow. And you're absolutely right. Most anembryonic pregnancies are thought to be chromosomal abnormality in the inner cell mass. Abnormal number of chromosomes. So that's an aneuploid embryo. But euploid embryos can miscarry for lots of different reasons. Sometimes it is to do with endometrial receptivity. Sometimes it's to do with the metabolics of the embryo. Just because an embryo is chromosomally normal doesn't mean that it will implant, nor does it mean it will continue. So there are lots of different reasons, but there could be metabolic. Sometimes weight. We certainly know that women who are overweight are far more likely to miscarry euploid embryos than women of normal weight. So there's metabolic environment, there's endocrine issues, there's anatomical. What if there's a polyp? A euploid embryo may, or a septum, a euploid embryo may miscarry. So there's lots of, I guess, non-embryo related things, and there are also some embryo related things that cause them to miscarry. So I hope that's helpful. Life of Brit, I know every clinic is different, but how long do you need to attend IVF appointments after a transfer? If all going well, do you then get a pass? do you get a pass out to your GP? You're right. Every clinic's different. Often, once you get to viability, so an ultrasound that shows a positive fetal heart and a well-grown embryo, it's reasonable to counsel on things like non-invasive prenatal testing or the Harmony test, you may know it as, and also to counsel on first trimester screening. But most of us will hand back to the GP or even hand on to the obstetrician, because many people will see their obstetrician before they hit that 10-week mark. So we provide you with a weaning regime for your medication, and then we'll hand you off back to your GP for ongoing care. Hello, Professor Yazdani, Professor Yazdani, lovely to see you on. My colleague from Queensland. Now, do we have any? No worries, Kayla. Please go back and do have a listen to the front of the live. But my pleasure. Any other questions about IVF? Brooke Adino, do you have any positive stories or facts to share about azoospermia cases? So many, Brooke, because azoospermia, or no sperm in the ejaculate, can be caused by lots of different things. And the one really good thing about working as an REI is that you can actually investigate the male, and I think it's really important to investigate the male. Figure out, is it a production issue? So are they not getting stimulation from their brain down to their testis to turn the testis on to make sperm? Is it because they might not have any sperm germ cells? So in fact, they have something like Sertoli-only syndrome. So that's an inherent problem within the testis itself. Or is it an obstruction issue? Perhaps they might have had a vasectomy previously, or they might have had a sexually transmitted infection that has caused obstruction within the vas deferens, or maybe they don't have a vas deferens because they have a variant of cystic fibrosis and they have an absence of the vas deferens. So there's lots of different reasons. Now, the ones where there's an obstruction, that's easy. You just go in and get sperm straight out of the testis because you know that it's going to be there. If they've got an issue with producing the hormones that turn the testis on, that's pretty easy to manage too, because we just give those hormones and it turns on the production of sperm. The difficult ones are where the problem is seen to be within the testis itself. So perhaps they don't have any germ cells and they're not able to produce sperm. Or they might have something called hypospermatogenesis, so there's spots within the testis that they don't produce sperm, and some where they do. In those situations, often we will refer on to someone who's very skilled in doing a deep search into the testis, something called a microteaser, where we open up the testicular body and we go sifting through all the seminiferous tubules looking for those that might contain sperm. And with a really skilled operator, you can often detect sperm in about 50% of cases. So there are loads of stories, but it's really important to try and figure out where the problem is so you can potentially overcome it or you can manage it. The answer is not always going to be sperm donation, but in fact, in some cases it is. No worries. Life of Brit. Vivanya. Hi, Dr. T. Is exercise like running allowed during the IVF process? Absolutely. My only advice is to let's exercise in moderation. And I was once told by my professor, encourage people to exercise as they would when they are 9 months pregnant. So you're hardly going to be running marathons during that time. And we certainly know that high levels of physical activity, intense physical activity, situations where you might have an energy deficit is going to interrupt that sort of brain ovary ovulatory cycle, and that could potentially impact on your ability to conceive. So I do think it's time to just perhaps pull back and lean into sort of more moderate exercise. And I do think some mindfulness activity is really important, something where you're just slowing down and being present, things like yoga, things like Pilates, where you're just concentrating a little bit on being grounded and being present. Is there any evidence for that? No. But do I think it's really good for you? Yeah. Mrs. English Lady, lovely to see you. How long does it take to find out if you're pregnant after a frozen embryo transfer? Well, how long should you wait, really, is what you're asking. The longer the better. So if you think about it, we're transferring a day 5 embryo, and technically speaking, you're going to have a positive pregnancy test if it's implanted at around about 10 days after that, 9 to 10 days after that. Would I encourage you to wait just a little bit longer, maybe push it out to that 2 week? Yeah, because I want to be able to tell you with great certainty you are pregnant. If you are testing right on the cusp of a positive HCG, it could be a little bit equivocal. And so I do think that there is some merit to just being that little bit patient so that we can give you a really robust answer about your pregnancy. But a great question, because I know all of you go out there and you do your home-based pregnancy test before I do your blood test. Gosh, these are good questions. Shall we keep going? I'm down to 5% battery, but I'm happy to keep going. Okay. LC DeMario, I think that's it. Would having 2 embryos transferred at the same time increase the likelihood of implantation? Yes, we know that double embryo transfer can increase the likelihood of implantation. It will also increase your miscarriage rates and it will increase your multiple pregnancy rates. So you really have to weigh it up. If you have a really good quality embryo, if you haven't had that many transfers before, if you've got a PGT tested embryo, so it's euploid, I probably wouldn't encourage you to do a double embryo transfer. But if you're doing, say, a day 3 transfer, and I certainly don't recommend that, if you have had several embryos transferred, if you've got 2 poorer quality embryos, then I certainly think it's a discussion point to have with your fertility specialist, and your situation should be weighed up for its own merit. Lauren Scott, do you have any advice for someone who struggles with a thin endometrium even on a medicated FET? I have a patient just like this at the moment. Are there foods or any other lifestyle changes which might help during the cycle? Well, one of the causes of thin endometrium is certainly atrophy, which can be due to a long time without any periods, so what we call prolonged secondary amenorrhea, often due to functional issues like over-exercising and under-eating. So I would certainly suggest moderation. However, in the vast majority of cases, they will respond with time and with sort of prolonged estrogen stimulation. But if you've got someone who has had a thin endometrium from the outset, you've tried all of the thin endometrium protocols that are out there, I don't believe that there is a lot you can do lifestyle, and I think that you have to get down to what is the pathology of what is going on here and what are some of the pharmacological strategies that you can use. But really, I don't think there's anything that you can actually eat that's going to change that. Pascal, could you explain what embryologists look for when they class embryos, and what is the chance of a B or C embryo implanting? Oh, gosh. Okay. probably not a C grade. All right, let me take this a step back. We grade embryos on different systems, but certainly the most commonly used system is the Gardner criteria. And we grade the inner cell mass as an A, B, or C, depending on how it looks, and the trophoblastic tissue around the outside, A, B, or C. And then you've got the stages of embryo development. So a 3 would be reached blastocyst, a 4 would be expanded, a 5 would, hang on a sec, a 3 would be early, a 4 would be blastocyst, a 5 would be expanded, and a 6 would be hatching. So if you got, say, a 6AA, I think that's right, or a 5AA, that's really great. And progressively, each of those will have an improved success for implantation and live birth rate. The difference remains whether you've determined that on a day 5 or a day 6. So if it's taken that, so let's say it reaches blastocyst at day 5, that's appropriate. But if it's reached blastocyst at day 6, then perhaps it's a little bit slow. So at day 6, you'd rather see something like a 5 or a 6, and day 5, a 3 or a 4. But certainly the better the grade, the more likely it is to create an ongoing pregnancy. I hope that's been helpful. That's the easiest way that I could generically explain that. Yes, Lauren, try Viagra, pessaries. They do work for some people. Oh, hello, Jill Louise G. Lovely to see you on. Monique Doherty. I can still go. In fact, I tell you what, guys, I've got 4 more minutes because then I'm going to go and pick up the little one from dance. Monique Doherty, 21. Sending baby dust to all you beautiful ladies. Oh, I love that, Monique. Thank you. Currently 27 weeks pregnant with my first baby, frozen day 5 embryo, little boy. Well done, Monique. Congratulations on all your hard work, you warrior. Staffy Mama Me, do you often have those pulling at the heartstring cases, and how do you wind down from those days? Yeah, totally agree with you, Staffy Mama. I definitely have pulling at the heartstrings. I have a lot of those. In fact, most of my patients are pulling at the heartstrings because everybody has a story, right? There is no... Every story is unique. Everybody's journey, I know, has been hard, and every single couple, single person, same-sex couple that comes to see me, I know I'm coming in halfway along their journey. They've already been on a journey themselves by the time they get to me. So understanding where they've come from and what their vision is for what they want to achieve is part of my passion, and that will always pull at my heartstrings because there are humans at the center of this. How do I wind down? Ask my therapist. Joking. How do I wind down? Well, I make sure that I give myself some me time every day, and for me, that is exercise. So exercise for me is my me time. I walk my dog and I never ever put earphones in when I walk my dog. So I'm being present. I do a lot of heart breathing. So when I find that at the end of a day I'm quite wound up, I'll actually place my hand on my chest and I'll feel the intake and outgoing breath. And I find just that alone helps to bring down the anxiety, and sometimes I will have to decompress before I go in and see my family, and so that's when I get outside and I play with the dog or do something that is just going to give me some time out before I interact with my family. So I don't know, does that help you guys? I hope it does. Helps me. Andy B, last question. What are your thoughts on PGT testing? Thank you in advance. So nearly out of battery. So thoughts on PGT. I think it's a game changer for people who are testing for genetic abnormalities. So things like cystic fibrosis. I think it's a game changer. And I would recommend that every single person does reproductive carrier screening, because right now it's free for a female to undergo reproductive carrier screening. and talk to your doctors about expanded carrier screening, because I think it is really valuable. For people who have translocations, recurrent miscarriage, I think it's a game changer. So PGT, I think, is really valuable. PGTA, so testing for aneuploidy. There is not good evidence under the age of 35 to show that it improves live birth rates. So I don't think it's for everybody. In Western Australia, we have guidelines, and I actually really like the guidelines. I think that being over 35, I think that having recurrent miscarriage or having recurrent implantation failure are really good indicators for doing PGTA. I can't promise you for sure that it is not without harm or impact on an embryo. We also can't guarantee 100% that we don't get it wrong. The accuracy is pretty good, and there are platforms, we certainly use them at Monash, which improve that accuracy pickup. But I do think that having guidelines around who can access PGTA and who can't, I think is important, because it's not without risk, it's not without extraordinary cost, and in some populations, I don't think it actually makes a difference to their outcome. So to invest in that for no improvement, I don't think it's worth it. Life of Brit. Oh no, I said that was the last one. Life of Brit. I'm going to answer that next time. Pascal. Oh, yes, I agree. Lovely to hear about Monique. My pleasure, everybody. Thank you so much for being on tonight. There were some awesome questions. If I can, I'm wishing all you guys an amazing next fortnight leading into Easter. I am off to Sydney for our amazing fire conference on Saturday to connect with all my colleagues and do some more learning. And I will hopefully catch you guys next week. See you later.